George is actually back in our home office, and he is responsible for our national policy and strategy from a company perspective. And I work here in California, so I cover the policy issues across our pharmaceutical sector with a large focus on the CNS mental health space. Is it on? Can you hear me? Okay. So this morning we're going to take you through some of the environmental changes that are happening because of the Affordable Care Act. And some people may reference the Affordable Care Act as Obamacare or healthcare reform. And we're going to just take, excuse me? No, that's okay. We're going to take you through some of the concepts of the Affordable Care Act as it pertains to your environment and the many changes in mental health, behavioral health. And we really want this to be a dialogue because we learn from you as well as the environment is changing, and we appreciate your questions. So please stop us at any time and ask us questions, and we're going to zoom in and out of this board as we tell the story and focus on the changing landscape. And one thing I want you to keep in mind is that, right now there's so much change going on that it feels like we're really in the midst of a terrible storm. But somebody always reminded me that after each storm there is a sunshine. So please keep that in mind, that we will get through this changing environment, and we will definitely come out on the side of a better environment for patient care, and the healthcare system will evolve accordingly. So I'm going to turn this over to George to take us through the national landscape, and then I'll bring it down to a more California perspective. And again, please feel free to interrupt us. Thank you.
Thanks, Kelly. It's great to be here with you today, and it's a special day, special meeting, so really it's a privilege to be here with Kelly to talk about this important topic. And when you look at the healthcare environment, and I'm going to kind of drill down on some of the national trends, and Kelly will go specifically to California. But when we were developing this presentation, just as way of background, I've been with J&J for 34 years, about 18 of those years in the mental health area. And when we were looking at developing this presentation, one of the things we found out from the research was that when you look at the severely mentally ill, for example, that one of the statistics was that that population lives 25 years less than the general population. Obviously, from my standpoint, it was like, that's got to be an error. There's no way in this day and age that could possibly be true. So I had people go back, and they came back and said, no, it's really true. So we included that in as kind of a startling statistic, because that's a quality measure that has to improve over time, no doubt about it. And we have to figure out, how do we get there? How do we get to a much better place for the mental health? So with that said, the purpose of this board is to examine the various challenges and obstacles that we face as patients, as consumers, as stakeholders in the system, and also to try to start talking about some of the ways that we can improve things going forward, working together. So I'm going to take you through 4 aspects of this board. First, focusing on the upper left-hand corner, talking a little bit about the mentally ill, some of the details behind that population, some statistics that you may or may not be aware of. Then secondly, and along that, on a little bit to the right, you'll see that map there. We'll talk about some of the key aspects of healthcare reform and how that will impact the mentally ill population. And then we'll go down and we'll talk about the revolving door dynamic for patients that I think we're all well aware of. And we'll talk about some of the reasons for the lack of communication at times, and the different sites of care that are impacted by that. Then I'll turn it over to Kelly, and she'll talk about 2 roads. There's 2 journeys there, the upper road and the bottom road. The upper road is indicated to be more like the current situation, with a lot of potholes and barriers along the way. And then the bottom road is hopefully a more optimistic road to recovery, where, with various things in healthcare reform, like expansions and new delivery models and quality measures, hopefully that'll, set the path for a better outcome for patients. And we'll end up with a discussion about quality mental health. As Kelly said, please stop me at any point. Again, we want to learn from you on what you're seeing, because obviously there's a lot going on in this area. So with that said, let me just say a few things about the statistic we talked about earlier, which is the 25-year difference in the life expectancy. A lot of people ask, why is that happening? What doesn't make sense? It just doesn't make sense. We've listed 5 reasons here, and maybe you have other reasons for that discrepancy. First of all, we have the stigma for this population. It's a big issue, and I think 1 out of 10 people with schizophrenia take their own lives. 1 out of 10. That's obviously a big number and something that really needs to improve. Secondly, you have the hospital readmissions. We found in our research that in 80% of the cases where people go up for treatment, that they end up having a relapse and going into the hospital again. Again, 80% of the time that happens. And, it's not uncommon for people to relapse 4, 5, 6 times over a several-year period. So after you've gone in and out of the hospital for so many times, that obviously has a cumulative effect on your health care. The third area is comorbidities, and maybe this is the most important area because 68% of patients with schizophrenia have one other comorbidity. And obviously, if you don't have the integration of physical and mental health, if these patients aren't seeing their regular physician, then very often you find out about this other comorbidity situation much later on, and then it becomes more difficult to take care of that situation. So that's a very important statistic, and that's why I think that contributes to the 25 years. And then, unfortunately, a lot of people in this group, are not employed, and as a result, their healthcare coverage is a bit spotty. Let's face it. If you are in a job and you have regular healthcare insurance and you have it over a number of years, that's one thing. But if you're in and out of the system and things are changing, and so that's when we get into healthcare reform and the expansions. Hopefully, that'll be an opportunity for us in this area. But right now, it's definitely a problem. And then lastly, if you're not going in and out of the emergency room, you might be incarcerated. You might end up in jail or prison. And we know that I think 19% of people that are in jail have some sort of mental illness. And so this has become another site of care for this population, and that's really unfair. So those are 5 reasons. I know there are more. If you can just fix 1 or 2 of those, that would probably improve all 5 of those and improve that 25 years statistic. Oh, okay. Yeah. So, I talked about. Is that a little bit better?
Just a little.
Comorbidities, where 68% of patients have one other comorbidity, and then unemployment, and again, 19% of people in jail have some mental illness. Yes.
Do your comorbidity statistics include drug use?
Yes. Yeah, addiction is a major problem in this population. It's a great one.
I'd like to know, because I know that a lot of people with mental illness, they take psych meds, but they also are like the medical marijuana, and what are they doing about that so that they're not, overdosing with their psych meds and their pain medications or whatever they want to call them.
I mean, that's a huge issue, and I know California legalized, right?
So I think that part of healthcare reform is also the mental health parity, making sure that the physical health and mental health have more parity. And in that regard, you'll have more oversight in terms of treatment options, access to various treatment, and
that may help with some of the other comorbidities outside of just chronic diseases. So I think we'll see that evolve more because of the integration of physical and mental health and the parity that is coming in 2014.
Well, because one of the things that I found out is like, if you are on a pain management thing, some of the pain medications, like MSI, will not pay for pain medications. And so a lot of these consumers are having to put out a lot of bucks just for their pain medications.
Right, so I'll talk a little bit about that. In California, we have been expanding with our Medi-Cal population and other populations because of a certain waiver with the federal government. And some of those plans, like MSI, are kind of temporary plans in place to make sure that there is some coverage, but it may not be the entire coverage that you'll be eligible for later in 2014. So that's what we'll talk about in the latter part of the conversation as to what to look for as we move into 2014 to enhance access to care and access to treatment.
Thank you.
Any other comments or questions? Are there any other reasons you think that we have this big discrepancy besides the ones that you mentioned? Not, I will move on. The second area, healthcare reform obviously is a huge issue all over the country. And if we were to have this conversation a year ago, we'd be asking the question, what is the Supreme Court going to decide about healthcare reform? And who's going to win the election? Those are two big question marks at the time. Now we know that the Supreme Court has ruled that Medicaid expansion is not mandatory, it's voluntary. And we also know that in terms of the individual mandate where people have to buy insurance by January 2014, we know that there's going to be a tax placed on those individuals that will not buy insurance. And so people will have to decide on the trade-off of paying this tax versus getting insurance. And people really going to have to get to the point of looking at what the costs are going to be to make that trade-off decision. And Kelly will touch on that a little bit in a little while. But so the Supreme Court, then you had obviously President Obama was reelected, so everything is moving forward. Beginning in October, you'll have sign-ups for state exchanges. I call them state exchanges. I should say exchanges. The other word for exchanges is marketplace. I don't know how many are familiar with the federal poverty level issue with that, but basically you have a situation right now, every state in the country has different federal poverty eligibility levels. But one group that is not really included today are childless adults. And that's the biggest demographic that's going to be included in Medicaid expansion. So that's important because when we look at our population of folks that suffer from mental illness, that's a big group for us as childless adults. So that's something to consider. The exchanges also, they go from 100% of federal poverty up to 400% of federal poverty, whereas Medicaid, goes from 100% down to whatever level. So the good news, and Kelly will get into this, is that California is moving ahead, full steam ahead, with both of those programs. And because in other states like Texas, we'd be having a whole different conversation because there'd be a group of patients that would not be given an opportunity to get insurance in the way that we are here in California. So you have Medicaid expansion, you have the exchanges, so there's going to be a big push starting in the summer for an October 1 implementation of these programs. And there's going to be a lot of pressure to have people sign up for insurance or Medicaid. But we know even today there's 5 million people that are eligible for Medicaid around the country that have not signed up even today. So will that change in January? Nobody really knows, but they're expecting about 10 million new Medicaid eligibles around the country, and originally it was going to be 15 or 16 million in the exchanges around the country. Now it's down to 4 million people. So they feel that because of the heavy cost sharing, et cetera, that there's going to be a lot of those people signing up. remains to be seen. So you have those two dynamics in play. You have Medicaid managed, Medi-Cal managed care, which is obviously, transitioning over the years. I'm sure you'll get to that. But in other states, they haven't been as progressive as California, and so that's an issue that's big to them. Then you have the whole focus on quality, and that's very important. I think that's providing some hope for us in the mental illness area, is that we can quality care is being managed in a much better way going forward. And I think we need, as advocates, to really fight to make sure that the quality measures for our area are included, along with cardiovascular and some of the other diabetes, etc. Any questions on this? We're going to drill down into the California piece. Yes.
Yes, are you talking, I have Medi-Cal and they don't cover dental or they cover the eye exam, but you have to buy the glasses, which I don't care. What I'm really concerned about is the dental. Is that going to come back, or do I have to pay for insurance?
I don't think that'll necessarily come back.
Right. So the governor yesterday released what's called his revised budget for May for this year, or into next year, I should say. And I don't believe that dental was included in the May revised budget, but that doesn't mean that there couldn't be a change. Again, I think one of the things we want to end with when we finish this session is the power of advocacy as a stakeholder, to have your voice be heard. And certainly, as a consumer, if that is a concern of yours, you should make sure that that's known. And I know that there was a question on a conference call yesterday with the Department of Healthcare Services that asked that question about additional dental and eye. So I know that's still a debate, but it was not in the governor's revised budget.
Yeah, because the eyes I could deal with, but the teeth I have to see it again real bad.
So I would say work through your advocacy organization, whether it's Mental Health America or if you belong to a certain agency or group, work with them to have your comments heard back up to the department, because this is the time to voice those concerns. Absolutely.
Okay.
Thanks for your question.
Any other comments or questions about healthcare reform? I'm going to switch to the evolving door dynamic, as is often referred to, for mental health patients. And really, when you look at this, there's really two major ways to look at it. First of all, there's a lot of people involved in the care of the mentally ill, and in a lot of cases, they're not talking to each other. And we'll get into why that might be happening in some cases. But you have, obviously the patient, you have the psychiatric nurse, psychiatrist, and then the primary care physician, which again, that's an area that they may not be talking to each other. You have the case manager. Really, the best case scenario would be for all these people riding together on the same bicycle, as you'll see later, really working towards the goal of improving care for the patient. But that doesn't always happen. The other complexity is all the different sites of care. And you can see it on there. But basically, you have, in addition to the emergency room at the hospital, you have the CMHC, the Community Mental Health Center. And obviously, that's an important area where the treatment is provided to mental health patients. But very often, if they relapse, they end up in the emergency room, or they'll end up in the crisis stabilization center, or the county jail. You see that a lot. And so there's people moving in and out of this. And so that really hurts the momentum around making sure that those patients are treated appropriately.
So what are they doing with the revolving door of the jails and prisons, of how these clients are actually, they get out and they go right back in, they get out, they go right back in because they're not getting the right medications, or they're not getting linked correctly, and there's no follow-up?
Yeah, I think it's very local. There's, we can talk nationally, but even in
that's exactly it, is that, as you know, services are delivered at the county level, a lot in California. So it's working with, the county department of mental health, with the other law enforcement agencies and so forth. And there are very good examples across California where there are positive things happening in terms of care coordination and better linkages. And as George mentioned, sometimes you don't have benefits as somebody's released from their situation, being incarcerated, and so that's a concern. And how do you get benefits more quickly? And as we automate and have electronic health records and more things that are easier to access to get those benefits more quickly, the quicker individuals will be linked to the appropriate service, and also treatment can continue or start appropriately. So there are some real positive signals here in California, but certainly it's going to take some time to ensure that everybody is taken care of appropriately upon release.
Thank you.
Yeah, so obviously a lot of complexity that leads to this revolving door dynamic, and it's something that, we have this conversation with people all around the country. That this is a big issue, and that's why the integration of physical and mental health is so important. That's why having the incentives for that communication is very important as well. Any other comments or questions on this chart? Okay, if not, I'll turn it over to Kelly.
I have a question. How many of you have a primary care physician? Okay. Well, that's a great sign, because that's, a testament, again, of that integration of both physical and mental health. And we'll talk a little bit about kind of this virtual medical home that's evolving. And really, it's just that primary care physician and team being the quarterback in terms of care. But I want to go forward and talk about two different roads. And we'll first focus on the current road, or I should say the road we have been on in terms of stakeholders. And you see that the traditional path is very fragmented. So to the questions that have already come up, there may not be appropriate linkages. If you're a patient and you're diagnosed and, either for the first time or have had illness for a while, you may be seen by multiple different people within the treatment team. Your care may not be as coordinated as it could be, and that's something that's a theme in the Affordable Care Act and healthcare reform, is to not only keep the care patient-centered, which is an important aspect, but also to coordinate the care better amongst different sites of care, treatment team, hospitals. So when there's a discharge from the hospital, that linkage, or if you're coming out of an incarcerated situation, that linkage. So the way that we access care currently is fragmented, and that's why you see changes evolving, and sometimes those changes evolve into that managed care system, and that is a result of trying to coordinate care more effectively at the local level. We also see that, as George alluded to, there are many incentives both in Medicare and Medicaid for helping providers and systems of care go electronic. So that's the important part, is that as we move towards more electronic records of health, then their coordination of care can be enhanced because people can talk to each other more effectively. And you also have access to that electronic health record. So again, it's to keep you a part of your treatment plan and keep the care patient-centric. But there are many policies that are evolving that didn't exist prior to the Affordable Care Act. And even for mental health and behavioral health, there were some gaps. And clearly, there are laws or bills in Washington and in Sacramento to try to fix those gaps, to ensure that not only the physical health, electronic health system is up and running, but also, again, that integration of mental health and physical health is clearly a goal of healthcare reform. And then I'm sure you're all familiar with not only California's budget crisis, but really across the country. There's just enormous financial pressures at the state and federal level. And I can tell you, in California, Medi-Cal is about 27% of the governor's budget. So clearly it's an enormous spend, and there are a lot of rich benefits here in California for Medi-Cal, unlike, as George mentioned,
some of the other big states, like Texas, very small benefit for their Medicaid patient population. In fact, there is a large gap of uninsured patients because they don't allow the eligibility criteria to be as much as California's eligibility in Texas. So there's a lot of positive things happening here in California, and you'll see California is one of the first states to start expanding the mental health population in other populations. But it still puts pressure on the system financially, and that's why sometimes hard decisions are made both at the federal level and at the state level. And again, you have a voice in that process. So as a stakeholder, whether you work with an advocacy organization or an agency, or just as an individual stakeholder, you have comment periods where you can be involved in shaping the policy and ensuring that it's the appropriate policy for you as a patient or a caregiver or a provider. Yes.
So if we wanted to get involved, how would we get involved? Because you're saying we can get involved, but there's really...
Absolutely. You know, the best way to get involved is through an organization like Mental Health of America, who's helping to host this conference, and all stakeholders, whether you're an advocacy organization like MHA or you're a provider of care, the associations like the psychiatric community has different associations that they're involved with. The health plans also get involved, but probably as a consumer patient, you would likely get involved in a mental health board at a county level and or advocacy organizations such as Mental Health or NAMI as well. They're very active at the state level and ask for feedback from their membership on a regular basis when rules and policies are being made at the state and federal level.
Yeah, because we have a Consumer Advisory Action Committee, and so that's why I'm wondering, because I'm wondering how to bring that up to them so that we could have, have our say at the state level.
Right. I know that the agencies here in California, Department of Healthcare Services, has been going out of Sacramento and meeting and having meetings at the local level. And so those are opportunities as well to engage the department in Sacramento who's helping to write these policies and shape them. So if there are, in Orange County, if there are meetings like that, that's another opportunity for you as an individual to ask questions and speak up and kind of give your perspective and point of view directly to the department.
Thank you.
Any other questions, sir?
Yes, if somebody's on either regular Medicare or disability, Medicare, what good is this policy? Does it do any good at all?
Well, yes, because for Medicare, again, Medicare and Medicaid are the two largest public payers in our country. And so with Medicare, actually Medicare is usually the benchmark for a lot of plans, Medicaid and other health plans. And Medicare was the first to provide incentives to providers to put electronic health records in their system. So, and what I mean by incentives is really just deferring some of the cost of putting those systems in place, but also encouraging that coordination of care and ensuring that there is appropriate linkage. So Medicare is out in front a lot of times in terms of a lot of these things that we're talking about and systems change. And so that you should see that as a benefit for coordinating your care more effectively or your loved one's care more effectively.
Do people on Medicare, do they have to buy the insurance too?
Well, Medicare is a benefit that you get.
That's a benefit, yeah. Right.
There is premiums attached depending on your individual situation. You would work with your treatment team or your provider to determine what would be best for you. And then there are different types of Medicare for hospitals, for outpatient care, for prescription. So you would want to ensure that you have the right Medicare kind of bundled for you as an individual or your loved one.
Now, I found that when people get hooked up with the emergency room first time, don't have insurance, they go in, the hospital takes them, but then the problem is to get the treatment that they need. There's still a lapse in the road consisting with them getting the services in an emergency basis.
Right, there certainly is, and a lot of that is because they may not have coverage. coverage. So part of healthcare reform is to ensure that more individuals have healthcare coverage, no matter what that is. That could be private pay, that could be Medicare, that could be Medi-Cal. But if they have coverage, that linkage will happen more effectively. And as we get more automated, more of these electronic systems in place, the eligibility will be faster. Today it may take 30 days, in 2 or 3 years it may take half that. So the more automated we become, I don't want to use the airline industry or travel industry as an example, but it actually is a pretty good one. If you look at booking a flight or booking a hotel, most people do that online or in some automated fashion, and it's very fast, and you get your confirmation. And healthcare is moving in that direction. It'll likely take longer because there are more systems in place, and really because the system is so fragmented right now. So it's going to take a longer period of time, but it's likely that things will be hooked up more quickly, then that linkage to appropriate treatment should be faster.
Okay, thank
Yes.
Okay, so my daughter's all squared away now with Kaiser, and what I really need to find out is how is that gonna change in 2014 with the lockdown? Is her co-pays going up? Is she gonna lose this insurance? Everything is fine now, but what I need to know, nuts and bolts, what is gonna change in 2014 with this situation? What do we have to worry about if anything?
Right, a lot will depend on age and income. So eligibility requirements are changing. So if your daughter is 26 years of age and under and you have employer-sponsored insurance, she could stay on your insurance, okay. It's Medi-Cal, okay. So with Medi-Cal, this is what we call or the healthcare reform refers to as coverage expansion. So really two main parts of coverage expansion. The Medicaid or Medi-Cal expansion and eligibility requirements are being increased. So currently, they were at 100% of federal poverty limit. They're now at 33% of federal poverty limit. So think of that as roughly $15,000. Federal poverty limit changes year to year. So again, I'll throw that number out to you, and just again, you have to look at your own financial situation or your loved one's situation and evaluate that year to year. So if they're eligible up financially to that 133%, they may be in either fee-for-service, Medi-Cal, or managed Medi-Cal. And a lot of that can be determined county by county or based on where you live. So if she falls out of that 133%, she could potentially buy into what George was starting to talk about, the exchange. And in California, this exchange is called Covered California. And actually the website is up and running, so you could Google Covered California, get access to the website. And what that does is it opens up a new benefit for individuals that don't currently have coverage or employer-sponsored coverage. So she could potentially have access to Covered California's benefits, and there are different plans, 4 different plans in that exchange that she can pick from, and that would determine what her cost sharing, what her deductibles or her out-of-pocket expenses would be based on what she picked in that Covered California exchange. Does that help a little bit?
I guess so. I guess I just wondered, is she going to be fine the way she is now? Is Kaiser going to continue with Medicaid? I guess I'm not getting an answer. I'm just getting a lot of talk. But what I want to know is, in 2014, are her benefits going to stay the way they are with Kaiser? Her co-pay stay the same, or is this going to change? And I'm not getting that answer, so I don't understand that.
Yeah, and I appreciate that because this is a very complicated time, and it's also not definitive in terms of being able to give you an exact answer. Because honestly, health plans change year to year. Medi-Cal benefits and Medicare benefits can change as well based on different policies. So to be able to say that your loved one's coverage today is going to be exactly what it is in 2014, I don't want to give you that answer as a yes, because it could be slightly different depending on what the plan decides to do for their coverage for 2014. What I will say is that based on her income eligibility, she may have different choices. I guess that's the best thing I would leave with the audience is that with healthcare reform, there will be additional coverage choices, and that may be an opportunity for her if she, say, wants to move to a different plan. She can look at Covered California or Medi-Cal if she's eligible and see what is the best choice and benefit for her or an individual. Yes.
You know, a lot of people came up to me and they said that about the HMOs. And now is the subsides, are they going to be HMOs as well? And how is it going to affect a lot of the HMOs that we have today?
Great. So in Covered California, again, we're looking at up to that 400% federal poverty limit. So think of Medi-Cal going up to 133% federal poverty limit, roughly $15,500 or so as an individual. As you add family, that can the numbers can change. Then Covered California begins, let's say where Medi-Cal leaves off, up to 400% of federal poverty limit. If we're talking about the Covered California marketplace or exchange, there are 4 different plans in that exchange: a bronze, silver, gold, and platinum plan to choose from. And they have different cost sharing, and if you're in that bronze or silver, you're likely to get some credits from the federal government to help pay for the premium each month for that cost. And so it really will depend on, again, the choice of the plan that you pick in terms of what your benefit structure looks like and what your cost sharing will be. Does that help you a little?
Well, it does, but it's like I'm still wondering, how these HMOs are going to be affected differently than like Medicare or Medicaid and all that, because like I'm on OneCare Cal Optima, which is, and so they give you, you get to pick for which company you want to go through, Prospect, Monarch, da 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 da. And it's like this big range of things. What I'm wondering is how is this coverage going to change in 2014, and how are the HMOs going to be able to deal with the services that they already give us, and how are they going to make them even better?
Right. So this is the current coverage will likely remain, and this is like new coverage for individuals that currently don't have coverage, or if you have coverage and you want to look at new options. It's a new way to look at additional options in the marketplace if you don't have employer-sponsored coverage. What I would say is that there is an HMO benefit in the Covered California, and there's a PPO, which is more just an open network. So there are different types of plans that you can pick from, and again, different types of premiums and cost sharing depending on what you choose. And all of the traditional plans that we currently know, Cal Optima and others around California, are going to participate in some fashion in the landscape as it moves forward. You may have some of the bigger plans, such as Anthem and others, may play more in the Covered California market, but they'll usually work through the local environment. So many of the medical groups that you mentioned will likely be the providers of care. And unfortunately, all of the contracts and all the details are not certain yet, because they're still in that bidding process and discussion process to make sure that they have the framework set. So the enrollment period, though, will start October 1. So as George alluded to, there'll probably be a lot of marketing and discussion about Covered California this summer. And that's why we wanted to have this discussion now, to alert you to what's coming so that you can be informed and you know what your choices are and you can have those discussions. But Cal Optima has provided a lot of services here in Orange County and will be participating in some fashion in many of these new models as we move forward to 2014.
I'm sorry, but I have a daughter, she's 22, and she's trying to get on
things that I think is great in terms of healthcare reform is that it's really not only a patient-centered discussion, but working through your treatment team. So a lot of work is being done to ensure that there's appropriate navigators and